Hello everyone and welcome to our module on bradycardia. The definition of bradycardia is a pulse less than 60 beats per minute. A normal heart rate is 60 to 100, so below 60 is slow and therefore that is bradycardic. And there are two ways that you can develop a bradycardic pulse. The first way is sinus bradycardia. This is what happens when there is slow SA node depolarization. If you look at this tracing at the top on the bottom of the screen, we've got a P wave followed by a QRS and then another P wave followed by a QRS. This is a bradycardic rhythm. If you determine the heart rate from the strip, you'll see that it's less than 60 beats per minute. And the reason it's less than 60 is because the P waves are just being generated at a slow rate, and that's sinus bradycardia. The second way you can develop bradycardia is through AV block. This is when there is blocked or delayed conduction through the AV node. So if you look at the ECG tracing at the bottom of the screen, this is an example of complete AV block. There are P waves being generated at a rate that is not bradycardic, but those P waves are not making it through the AV node and the His-Purkinje system to the ventricles to generate ventricular depolarization. Because of that, the ventricles are depolarizing on their own at a much slower rate. So we have QRS complexes being generated at a very bradycardic rate. And we'll talk about both sinus bradycardia and complete heart block in this video. Let's start by talking about the symptoms of bradycardia. First of all, you should know that many patients you'll see are bradycardic and they have no symptoms. And that's because symptoms only occur if the bradycardia is severe. So for example, if the heart rate gets all the way down to 30 or 20, that will often cause symptoms. Or if it's persistent, if you have bradycardia at rest and it doesn't go away when you get up and exert yourself, that will lead to symptoms because you need your heart rate to pick up with exertion. So depending on the severity, bradycardia can be asymptomatic or symptomatic. When symptoms do occur, some of the common symptoms are listed on this slide. Patients can be fatigued and say they're tired from a bradycardic rhythm. They can have exercise intolerance. Like I said, if your heart rate doesn't pick up with exertion, that's going to lead to exercise intolerance. Patients may become dizzy, and then in severe forms, patients can have such a low cardiac output from bradycardia that they can develop syncope. So now let's talk about sinus bradycardia. This occurs when there's a sinus rate at less than 60 beats per minute, meaning that P waves are being generated at a rate of less than 60 per minute, and all those P waves are being conducted to the ventricle to generate a QRS complex. This is often an incidental finding, and it often is found in patients who have a reason to have bradycardia. For example, patients taking beta blockers or calcium channel blockers often develop sinus bradycardia, and that's because one of the effects of these drugs is to slow depolarization in the SA node. Well-trained athletes often have sinus bradycardia at rest. That's because these patients have very healthy hearts, and when they're in the resting state, the heart tends to beat at a slow rate. Usually you do not need to treat sinus bradycardia, only is it treated in rare, severe cases. For example, if something causes the heart rate to get down to 30 or 20 beats per minute, that can require treatment. There are a couple of options to treat sinus bradycardia. If you want to treat it in the short term, for example, a patient you're seeing in the hospital who has a very slow heart rate, there are some drugs you can use. Atropine is a muscarinic antagonist. It blocks the parasympathetic nervous system and therefore it increases the heart rate. Dopamine and epinephrine are also drugs that can be used to treat sinus bradycardia. These are beta-1 agonists, and they will increase the rate of depolarization of the SA node. And then patients with marked sinus bradycardia, especially if it is symptomatic and chronic, often go on to require a pacemaker. And we'll talk about pacemakers later in this video. Next, let's talk about sinus node dysfunction, which is also called the sick sinus syndrome. This refers to sinus bradycardia because of abnormal SA node function. And usually this occurs in older patients and it's caused by age-related changes. As we age, some of our conduction system in the heart is replaced by fibrous tissue. And if enough fibrous tissue develops in the SA node, that will lead to abnormal function of the SA node. This can cause sinus bradycardia and can cause any of the symptoms of bradycardia we talked about earlier, including exercise intolerance, dizziness, or syncope. But one special way that the sick sinus syndrome often presents that you should be aware of is slow or absent SA node function after atrial fibrillation converts to sinus rhythm. Let's take a look at this tracing on the screen here. On the left side of this tracing, this patient has atrial fibrillation. And atrial fibrillation can spontaneously convert to sinus rhythm on its own. What's happened here is this patient has spontaneously converted to sinus rhythm, but because their sinus node is sick, it takes a long time before the first P wave occurs. This is called a conversion pause because it's a pause that occurs at the conversion of atrial fibrillation to sinus rhythm. And if this pause is long enough, it can cause patients to faint. So many patients with AFib faint when they convert from AFib to sinus rhythm, and that's because they have sinus node dysfunction. And these pauses are called conversion pauses. And this is one classic presentation of the sixth sinus syndrome. And most patients who have the sixth sinus syndrome with any symptoms, whether that's a conversion pause or dizziness or syncope, they require pacemaker implantation. So now we've talked about sinus node problems. Let's switch gears now and talk about AV block, which is the second way by which patients can become bradycardic. AV block refers to slowed or blocked conduction of electrical impulses from the atria to the ventricles. On the ECG, this can present with two problems. The first thing that you may see in patients with AV block is a prolonged PR interval. If you look at the bottom left side of the screen here, the PR interval is from the beginning of the P wave to the beginning of the QRS interval. And a normal PR interval is about 200 milliseconds or so, which is one big box wide. This PR interval is about 400 milliseconds or two big boxes wide, and that is prolonged. And that's one of the things you can see on the ECG if there is an AV block present. The second thing an AV block can cause is a non-conducted P wave. Let's look at the right side of the screen here. We have a P wave here, and it's conducted to the ventricles, and therefore it generates a QRS complex. We then have a second P wave, but it does not generate a QRS complex. That's because it has become blocked somewhere between the atria and the ventricles. No electrical activity has reached the ventricles, and that has caused a non-conducted P wave. The second finding you can see on ECG in patients who have AV block. Let's talk about the symptoms of AV block. AV block is often asymptomatic and incidentally noticed when an EKG is done for some other reason. This is especially true in the milder forms of AV block we'll talk about in a minute. These are forms where there are few or no non-conductive P waves. But sometimes in more severe forms of AV block, there can be symptoms from bradycardia. This especially happens when many or all of the P waves are not conducted. So symptoms that can occur in these cases are things like fatigue, dizziness, syncope, and symptomatic AV block is often treated with a pacemaker, and we'll talk more about this later in the video. Let's go through a brief review of the anatomy of electrical conduction in the heart. So the SA node is the pacemaker of the heart, which generates electrical activity. That electrical activity travels through myocytes in the atria, and then it's all funneled through the AV node. After it goes through the AV node, it goes to the His bundle, and then to the bundle branches, finally to the Purkinje fibers, and from there into the ventricular myocytes, which causes them to contract and generates the QRS complex. So when people have AV blocks, they can either have a problem in the AV node, or they can have a problem in the His bundle, the bundle branches, or the Purkinje fibers. Problems with electrical conduction in any of these systems here will cause an AV block. And in general, we divide AV blocks into two causes, those that occur due to problems in the AV node and those that occur due to problems in the His-Purkinje system, which includes the bundle branches. The reason we make this distinction between AV block that occurs in the AV node versus the His-Purkinje system is because AV nodal disease is usually less dangerous. The reason for this is that conduction through your AV node improves with exertion. Anytime your sympathetic nervous system activity rises, that will increase the speed of conduction through the AV node. So if you have an AV block because of an AV nodal problem, often it will go away when you exert yourself, and that makes the problem more benign. In contrast, His-Purkinje disease is usually more dangerous. That's because it usually does not get better with exertion, and it often progresses to complete heart block where no P waves are being conducted to the ventricle. And most patients who have His-Purkinje disease usually end up requiring a pacemaker. So how can you tell whether a patient has AV block from a problem in the AV node or from a problem in the His-Purkinje system? Well, the way you do that is by looking at the ECG in the patient with AV block. And when we look at AV blocks on the ECG, we divide them into one of four types. The first type is called type 1 AV block, and in this form of AV block, there is prolongation of the PR interval only, and all P waves are conducted. There are no non-conducted P waves. In type 2 AV block, some P waves are conducted, but some are not. And there are two subtypes of type 2 AV block. One's called Mobitz type 1, and the other's called Mobitz type 2. And I'll show you examples of both of these in a minute. And then the final type is called type 3, and in type 3 AV block, there's no impulse conduction from the atria to the ventricles. None of the P waves are making it through to the ventricles to generate a QRS complex. Shown on this slide is an example of first-degree AV block. In first-degree AV block, every P wave is followed by a QRS complex. However, the PR interval is prolonged. A normal PR interval is about 200 to 210 milliseconds. If you look at this PR interval here, it begins at this point and ends at this point. It's about 300 or 400 milliseconds, so that is prolonged, and therefore this is first-degree AV block. First-degree AV block is usually caused by slowed conduction in the AV node, and people who have this finding on their ECG usually are taking a drug that causes slow conduction in the AV node. So for example, patients of mine who are taking beta blockers or calcium channel blockers will often have a first-degree AV block on their ECG. This is also a classic finding in well-trained athletes. Well-trained athletes like marathon runners have a very healthy heart, and at rest they have high parasympathetic nervous system tone. This leads to sinus bradycardia and also a prolonged PR interval. And the treatment for first-degree AV block is usually nothing. That's because all the P waves are leading to electrical conduction to the ventricles and generating a QRS, so there are usually no symptoms and no treatment required. As I mentioned earlier, there are two forms of second-degree AV block. Let's talk about the first one, which is Mobitz type 1, also known as Wenckebach. If you look at this tracing on the screen, we have a P wave followed by a QRS, then another P wave followed by a QRS, and then we have a P wave where there is no conduction to the ventricles and no QRS, so that's a dropped beat. So anytime you see some conducted P waves and some dropped beats, you're usually looking at a case of second-degree AV block. And what makes this Mobitz type 1 AV block is that the PR interval is progressively getting longer with each heartbeat. If you look at the first beat on the left side of the tracing, this is the PR interval from here to here, so it's this long. If you look at the next beat, this is the PR interval from here to here, so it's gotten longer. And then we have a dropped beat, and then we go back to a shorter PR interval. So that's a classic finding of Mobitz type 1 or Wenckebach, is progressive prolongation of the PR interval followed by a dropped beat. I've cleared away my ink so I can show you another classic finding of Mobitz type 1, and that is called grouped beating. If you look at this tracing on the screen, we've got two QRS complexes together, then we have a pause, then two together. That's called grouped beating, and that's a classic finding in Mobitz type 1 or Wenckebach. And then once more, I've cleared away my ink to show you that in Mobitz type 1, the RR intervals are not regular. This is an important finding to help distinguish Mobitz type 1 from other forms of heart block. So let's look at the RR interval between the first two QRS complexes. And now let's look at the RR interval between the next two. You can see that it's varying. We've got two close together and two further apart, and then we go back to two that are close together. These RR intervals between QRS complexes are irregular, and that's also a hallmark finding of Mobitz type 1. And the causes of Mobitz type 1 or Wenckebach are basically the same as first-degree AV block. This problem is just a more severe version of block in the AV node, and therefore anything that can slow conduction in the AV node and cause first-degree AV block can also cause Mobitz type 1 or Wenckebach. And just like first-degree AV block, there's usually no treatment for Mobitz type 1. And the reason for this is that as you exercise, conduction will improve and the drop beats will go away. So people who have Wenckebach may have a drop beat just like this one right here. They have a P wave that doesn't lead to a QRS interval. But when this person begins to exercise, conduction through the AV node will increase because of increased sympathetic nervous system activity, and that will make these long PR intervals go away, and it will make this drop beat stop being present, and basically the patient will develop a normal sinus rhythm with exercise. So because this goes away with exercise, usually it doesn't lead to symptoms. Your heart rate is still able to pick up normally, and that's why you usually don't need any treatment. Here's another example of Wenckebach just to make it very clear to you. First of all, notice that we have grouped beating. We have two QRSs together, then a pause, then two together, then a pause, then two together. That's classic group beating. Notice that the RR intervals are varying. We've got two close together and then a long one. And then if you look at the PR intervals, you can see we have a short PR interval and then a longer PR interval, and then we have a P wave that is not followed by a QRS complex indicating a drop beat. All classic findings of Wenckebach. The second type of second-degree AV block is called Mobitz type 2. In this form of AV block, you also have some conducted P waves and some non-conducted P waves, but the main distinction between Mobitz 2 and Mobitz 1 is that in Mobitz 2 you do not see progressive prolongation of the PR interval. Let's start by looking at this red strip at the top of the screen. We've got a PR interval of this length, and then we've got another PR interval of the same length. There's no prolongation from one beat to the next. And then we have two drop beats in a row and then a return to conducted P waves. So this is the hallmark of Mobitz type 2. You've got non-conducted P waves without a steady prolongation of the PR interval preceding those non-conducted P waves. The source of the electrical conduction block in Mobitz 2 is usually the His-Purkinje system. And because the block is usually in the His-Purkinje system, most patients with Mobitz type 2 also have a bundle branch block. Remember that the bundle branches, the left and right bundle branches, are part of the His-Purkinje system. So if the His-Purkinje system is sick, you often see a bundle branch. And if you look at this red tracing at the top of the screen, the QRS complexes are prolonged, and that's consistent with a bundle branch block. Mobitz type 2 is often symptomatic. These patients often have dizziness or syncope, and in many cases it requires treatment with a pacemaker. And there's a second example of Mobitz type 2 on the screen here just for comparison in this gray tracing. Notice that we have a conducted P wave here, a non-conducted one here, and then several other conducted P waves. We do not see progressive prolongation of the PR interval as we look from one P wave to the next. The final form of AV block is called third degree AV block, also known as complete AV block. In this form of heart block, there is no conduction of electrical impulses from the atria to the ventricles. Let's look at this tracing on the screen here. We have P waves marching out at a certain interval. There's a P wave there. There's one buried here in the T wave. There's another one here. And then we have QRS complexes that are marching out at a completely separate interval on their own. There's one here, one here, one here, and one here. There is no relationship between these P waves and the QRS complexes. They are completely separated from one another. And now I've cleared away my ink to show you some of the key features of third degree AV block so you can recognize it in an ECG. The greatest point of confusion in identifying third degree AV block for most students is that people will think it's Wenckebach. You will think that you have a short PR interval here and then a longer PR interval here, and you will think that this is Wenckebach, but this cannot be Wenckebach. And the reason is because you have regular RR intervals. That makes Wenckebach impossible. Notice that the QRS complex here is followed by another one at a regular interval and a regular interval all the way throughout the ECG. In Wenckebach, you have that group beating I showed you before. You have those irregular RR intervals. On this tracing, you have regular RR intervals. They're all the same, and that means this cannot be Wenckebach, and it must be complete or third degree AV block. This form of AV block is usually symptomatic. Most patients have dizziness or syncope, and the treatment is with a pacemaker. Here's another example of third degree AV block. So we've got P waves here marching out at a certain interval, and you might think that this is Wenckebach and that this is a short PR interval and this is a long one. But if you take a step back and look at the entire tracing, these QRS complexes are perfectly regular, and that means this cannot be Wenckebach. It has to be third degree AV block. You should be familiar with Cannon A waves, which are a finding on physical exam in patients who have complete heart block or third degree heart block. These occur when the atria contracts against the closed tricuspid valve. So normally, when the right atrium contracts, the tricuspid valve is open and blood can be pushed into the right ventricle. However, in complete heart block, the atria and the ventricle are out of sync. They are depolarizing at different times, and sometimes the right atrium will contract, but the tricuspid valve will be closed. When that happens, blood will be pushed upward towards the neck, and you can see this on physical exam. It's called a Cannon A wave. If you look at the venous pulsations in the neck of a patient lying at 45-degree angles like this, you will see intermittent bulges in the venous pulsation. Those are Cannon A waves, classic finding of complete heart block. I've already mentioned some causes of AV block in this video, but I'll summarize them on this slide. First of all, there are many forms of drugs that can cause AV block. Beta blockers and calcium channel blockers, for example, can slow the sinus rate, so they can cause sinus bradycardia, but they also slow conduction through the AV node, so they can potentially cause forms of AV block. The drug digoxin, which is an inotrope, it makes the heart contract more vigorously. This drug also has a second effect where it slows conduction through the AV node, and therefore digoxin, especially digoxin toxicity, can cause many forms of AV block. The vagus nerve supplies parasympathetic innervation to the heart, so anyone who has high vagal tone, meaning they have lots of parasympathetic nervous system activity going through the vagus nerve to the heart, people who have this can have sinus bradycardia, but also can have slow conduction through the AV node. So the classic group that has high vagal tone is athletes, like this marathon runner shown on the slide here, and we mentioned this earlier. Athletes at rest often have a sinus bradycardia, and they also have slow conduction through the AV node, so they sometimes have evidence on their EKG of first-degree AV block or Mobitz type 1 AV block. And then lastly, the reason most of the patients I take care of have AV block is from age-related changes to the conduction system. As we age, there is a certain degree of fibrosis and sclerosis that occurs in parts of the conduction system, like the His bundle and the bundle branches in the Purkinje system. And sometimes this progresses to the point where patients have complete AV block. And this is why many elderly patients you'll see on your clinical rotations will have pacemakers. That's because of age-related changes like this that occur in the conduction system. I'll finish with this slide and briefly discuss pacemakers. So pacemakers can be used to treat symptomatic bradycardia. They can treat sinus node dysfunction. You can have a pacemaker that causes depolarization of the atria and takes over the job of the sinus node. Pacemakers can also treat high-grade AV block, usually Mobitz type 2 or third-degree AV block. In these cases, the pacemaker will depolarize the ventricle, and therefore it can make sure that electricity gets to the ventricle in cases of high-grade AV block. And as I've mentioned throughout this video, pacemakers are generally only used in patients with symptoms like syncope or dizziness. That's because implantation requires a surgical procedure and carries some risk. Pacemakers are small devices. They can fit in the palm of your hand like this one shown on the screen here. And in patients with pacemakers, if they have a chest x-ray, you can see the device. It's usually in the left side of the chest, right below the collarbone. And you can also see the wires. So the wires go through the venous system, and wires may go to the right atrium. Those wires will depolarize the atria to take over the job of the SA node. And wires can also go out to the tip of the right ventricle. Those wires will depolarize the ventricles in cases of AV block. And that concludes our video on bradycardia.